top medical stabilization center for adults with eating disorders for too medically compromised patients to receive care in a mental health setting. After 7 years as the medical director of Acute, she left to pursue her vision of outpatient care, founding the Gaudiani Clinic. During her years at Acute, Dr. Gaudiani became a nationally recognized internist for her work on the medical complications of eating disorders. She has lectured nationally and internationally, is widely published in the scientific literature, is on the editorial board of the International Journal of Eating Disorders, and sits on the board of the International Association of Eating Disorder Professionals as the only internist. Dr. Gaudiani is one of the only outpatient internists in the U.S. who carries the Certified Eating Disorder Specialist designation. In founding the Gaudiani Clinic, she has established a nationally unique outpatient medical setting program, not dictated by the restraints on visit time or insurance rules, where strong, supportive, and healing relationships with patients help them achieve wellness while remaining in their communities. Please note that at 9 o'clock, we will have an additional 30 minutes for additional Q&A if you are able to join us. But before we get there, please help me welcome Dr. Jennifer Gaudiani.
Thank you so much, Kevin, for a lovely introduction, and thank you all for having me here. I had the great pleasure of meeting Dr. Berland and Mrs. Berland yesterday, and it is truly an honor to be here under their names, and of course that of Dr. Goldman. Thank you all for joining me this morning. We're going to talk about palliative care and eating disorders, which many of you may think right out of the gate must be a mistake, because how could an eating disorder possibly be terminal? And I hope over the course of this talk to really help bring us all into the fold of what can transpire with this rather remarkable patient group. I have no financial disclosures except the fact that I have my own clinic. Our objectives today are to get a better understanding of eating disorders, including their morbidity and mortality, to understand the really wide variety of end-of-life considerations through a case-based discussion, and to gain familiarity with the concept of what end-of-life care and palliative care might look like for this population of patients. When we talk about eating disorders in this context, we're almost invariably talking about anorexia nervosa. And so I'll be focusing primarily on that today, although in later lectures today I will also be covering more of the broad spectrum of the medical complications of eating disorders. The many-sized egg photograph is meant to remind us that eating disorders come in all shapes and sizes. You can't look at somebody and know by their body size or shape that they're well or that they're healthy. And it's important for all of us to acknowledge the stigma that patients face in multiple body sizes, and certainly our patients in larger body sizes face it. Now, anorexia nervosa is one of these complications, one of these medical problems that really stems from a heritable set of traits with an environmental trigger. And I should say from the outset that it's an extraordinarily complex problem that we can't exactly identify one gene, one environmental trigger, but we understand it and we hold space for it to be very complicated. But we can broadly understand it as having a genetic component because of the temperamental traits passed down by parents to their children. The vast majority of my patients are among the smartest, most sensitive, kindest, hardworking, dedicated, anxious people I've ever met. And indeed, in speaking to a room full of medical professionals, you may all be on that spectrum yourselves, which is one of the reasons that I find working with this patient population so compelling. A little bit of there, but for the grace of God when I. And those traits, of course, are inherited from highly competent, highly intelligent, sensitive, thoughtful, driven parents. And of course, this set of traits is really productive as we all here can attest. But when you get a double helping of these traits, and you're really on the far side of the bell curve of these particular traits, and you're now awash in a society that focuses on thinness, fat phobia, proper eating, doing things the right way at all times, with failure being a particularly complicated concept right now, then you might potentially set fire to an eating disorder. And people say, well, you know, these traits have been here throughout history. Why now? What's going on now that's different? And I think it's helpful to use a medical model of the heritable traits environmental trigger that perhaps we're all somewhat more familiar with, which might be, for instance, among a Native American population and the medical problem of alcoholism. We know that the genetic propensity for alcoholism was present as far as liver enzymes and brain response to the substance. But until alcohol was in the environment, of course, there was no alcoholism. However, once alcohol and that set of traits mixed, suddenly there was a huge population of people who had the disease. So similarly, it's really been in the last couple of generations that this extreme focus on thinness and dieting and fat phobia has been prevalent. And so it would seem to be that there is a relationship between that societal trigger and the advent of increased incidence of eating disorders. The epidemiology shows that 0.5 to 1% of American women have anorexia. Typically, about 90% of patients are women, but I certainly see plenty of male patients, and I wouldn't be surprised if I were to find that the incidence of male patients with eating disorders is on the rise in the coming years. Anorexia nervosa carries the highest mortality rate of any mental illness, which was a fact that surprised me 8 years ago when I got into this field. The stats are very grim about how the course of recovery proceeds. Indeed, perhaps 50%, just half of patients, fully recover from their anorexia nervosa. 30% may improve, but never fully get rid of the voice and acting on the behaviors that answer to the voice's demand. And 20% may develop a severe and enduring version of this disease. Many patients with anorexia nervosa will die from it. Half of those are from medical cause: hypoglycemic PEA arrest, cardiac arrest from hypokalemia, aspiration pneumonia from weakness of swallowing. The other half die from suicide because this is a profoundly intolerable disease. This is not a disease of white teenaged girls who just are so superficial that they want to be skinny. This is a disease that covers the entire age spectrum. In fact, at Acute, my former program, fully 25% of the adults who admitted were above 40. And I had patients in their 60s with classic anorexia nervosa. This is a disease that covers the entire gender spectrum and all socioeconomic status and every possible patient you could imagine. Interestingly, those with anorexia have a 6 times mortality rate compared with their age-matched peers, just receiving the diagnosis of anorexia nervosa. And for those who are the most severely impacted, among those, the ones that I cared for at Acute, where the BMI on admission on average was 12.5, but where I saw patients who had BMIs in the single digits, the death rate is 45 times that of their age-matched peers. As I said, even with really good treatment, many do not fully recover from their eating disorder. And so a term called severe and enduring anorexia nervosa, or severe and enduring eating disorder, has been developed. And increasingly, the medical literature is focusing on this group of patients and wondering how we can ameliorate their disease and help them have a better quality of life. Because these, many of them, are the patients who frankly torment, to a certain extent, hospital and eating disorder staff, entering hospitals, refusing care, spreading their anxiety about what's going on to the entire care team and causing a great deal of consternation because they remain deeply compelling people. and then leaving the hospital without having made substantial progress. Full recovery, though, is absolutely possible from eating disorders. One of the two people who got me into this field was my sister, who had an eating disorder and has been fully recovered for 10 years. She was the one who most inspired me to do this. But I have permission from this former patient of mine from years ago when she was on acute. She had been sick for 12 years by the time she entered acute in her mid to late teens. This was a girl who bottomed out her BMI in the 10 to 11 range and was pretty famous around the country for entering treatment programs, leaving them, being so anxious that she would hide food in the covers when she could possibly get away with it. And I remember it was a time similar to this time of year that she and I sat, and she said, "Dr. G, I have to leave. I have to be home for Easter. I can't stand this. You're gonna make me fat. I can't deal. Please just let me go home to Easter. In fact, I don't care if I die." And I told her in her 21-year-old wisdom, "No, I'm not going to, because I believe you can get better from this. And I can ask you, I'm going to convince you to stay in treatment here at acute and then to proceed with a full course of treatment at a fine eating disorder program. And if you won't do it voluntarily, I will court mandate you. Because I believe in you and you've never fully weight restored before. I don't know what happens to your brain when it's fully nourished. So we're going to have to do that." And I talked to her dad, I talked to her mom, and she did complete treatment, and she's now been fully recovered for years. And I mean, she's just gorgeous, and she'll write me every couple of months and say, "Hey, Dr. G, I'm doing great, I'm back in school, here's my new tattoo, life is good." One of the things that I most love about taking care of patients with eating disorders is that perhaps nowhere more than in this field can I help them reunite body and soul. Because Western medicine, of which I am a practitioner, likes to keep soul over here and body siloed over here, and ne'er the twain shall meet. But all of us in this room who have an interest in this topic and in palliative care and in ethics understand that we cannot treat patients with the two of those separated. That in fact, it's one of the greatest privileges to be able to sit and understand that the soul affects the body and vice versa. And that it's in fact a privilege as a physician to understand that there are unmeasurable aspects of wellness and of illness, the things that are not black and white or exactly correct or algorithmic, that we get to help patients bring together. And it's one of the things that I most love about this field. So we'll talk about Christy, who is a former patient of mine. She's a 36-year-old woman who's had her eating disorder since she was 14 years old. Anorexia nervosa, binge purge subtype, for the last 2 years, in that instead of purely restricting calories, she now additionally abuses laxatives quite severely. And these patients know that they can't lose calories in their stool, but they have a profound need to be empty. They want nothing in them. And therefore, constantly taking laxatives in order to have diarrhea to the point where their stomach feels flat and their system feels empty is a constant temptation, compulsion. She's been in and out of treatment countless times at good centers, but each relapse is worse and happens faster and more easily than the last one. She has fully weight restored several times, so she's not a patient who serially leaves treatment early, as many patients do. She arrives at acute for the first time in 2010 at 68 pounds and 5 feet 2 inches tall. She stays 2 weeks, does the full treatment course to become definitively medically stable, and discharges at 73 pounds to a residential eating disorder program of good repute. There she bonds with the staff, engages, and stays in residential care for 2 months, discharging at 104 pounds, which is a perfectly reasonable weight for somebody at 5'2". This should be the treatment. getting therapy every single day, doing group work, getting nourished, being on the proper medications. This should be it. But she relapses immediately after she leaves. And this is a woman with a master's degree who has a high-up job in a bank. She represents to acute in 2011 at 63 pounds. She's quite weak, falling at home when she walks her dog. She has dysphagia from weakness of her swallow muscles, really severely ill and quite volume depleted from her laxative abuse. But on the night of admission, I'm called back into her room and she says, "Dr. G, I've made a mistake. I'm not ready to do this. I want to leave against medical advice." I sit with her and I say, "Christy, you are so starved and so uncomfortable now, and your potassium is 1.8, and your bicarb is 42. You are truly critically ill right now, and P.S., your glucose is 45. I can't let you leave right in this moment because you are too critically ill, and how can you make a decision right now with this level of starvation? Will you please do me the honor of staying 1 week? Let me tune you up, give you gentle IV fluid, get your electrolytes in a proper situation, and give you some nutrition. Then let's make this decision together, please." And she says, "Oh, Dr. G, okay, fine." So she stays and leaves 6 days later against medical advice. But of course, prior to letting her go, given how ill she is, we do all the things that you guys do here. We do a psychiatry consult. We have a decision-making evaluation. We find that she has capacity. And I've always been passionate about appropriate goals of care, palliative care, end-of-life discussions dating back to when I was in medical school. And so I sit with her and I have a really long talk about, do you understand what this could mean? We sit and we have a speakerphone call with her parents, and I help them understand that this may be it for her, and that I love her and that she's always welcome back, but that she doesn't have it in her soul to proceed right now. She signs a DNI order with her parents present once she gets home and to Virginia with her primary care provider. But no hospice service in her home state of Virginia will accept that anorexia nervosa could possibly be a terminal disease, and they decline to see her. Her primary care provider fires her because she's such a difficult patient. In 2002, she writes me the following: "I know this is my decision, and I could choose to continue to suffer, but I am in so much pain physically, I'm not sure how much more I can take. I still walk with a cane, and my legs work some of the time. I'm unable to really bend over without being in pain, and I can't bend my knees all the way. Basically, if I fall or end up on the ground, I have to call someone to get up. My current weight, as of a few days ago, is 50 pounds, and I'm on about 35 to 50 laxatives a day. I don't throw my food up. Do you have room at the hospital for me?" So she admits, of course. I say yes right away. She's now 52.7 pounds, 48% of expected body weight, profoundly dehydrated, critically ill, in multi-organ failure. Her LFTs are in the 500s. Her bone marrow is in full failure. She has cognitive slowing, and this is a woman with a brilliant IQ who's witty and sarcastic and snappy. She can't taste anything right and asks for a nasogastric tube because food has a tinny taste to her. But within a week, she once again talks about leaving acute. And she says, I just don't have this in me. Treatment doesn't work for me. Why am I going to go through 4 more months of treatment, Dr. G, when I know it's not going to work because it never has? But she's absolutely not suicidal. She is, however, deeply ambivalent about whether recovery is possible for her. And she's aware that it takes a sacrifice to engage in the level of treatment that she's now facing down. I managed to keep her for 3 weeks. And at this point, her body weight is 70 pounds with some persistent edema from rebound edema from laxative cessation, even though we've given her every ameliorative agent we knew how. She says she just has to leave AMA. She has parents, a sister, and nephews near her Virginia home, and she arranges some follow-up. Of course, her PCP still fired her. I talked to her sister, and I remember sitting on a spring day in my driveway on a weekend, talking to her sister on the phone about how she was going to discuss this with her little boys and how they were going to see Aunt Christy, and how, they felt uncomfortable hugging her because she was so skeletal, but she was so close to them, and how could we make this work? I keep trying to get her to stay, and I brought everything I had, and I've got a pretty good arsenal. But she understands the risks of leaving. She certainly doesn't want to die, but she just can't tolerate going through it again. And I keep her family closely updated with her permission. In September of 2012, she lets me know that hospice is still not really comfortable with anorexia nervosa, but at least they've given her a hospital bed and some oxygen. She's living with her parents now. She emails me when she's 39 pounds in September. She can't move and has bed sores. She wants to come back to acute to take the edge off, but doesn't still plan on a full recovery. It's clear that there's no way she could fly commercially, so I said, okay, go to your local hospital, get admitted, I'll arrange an air ambulance, we'll get you to me. But the whole team wonders whether this is futile. She chooses instead to remain at home and survives 2 more months before her body finally lets go. So you can see this is a disease that affects grown-ups, really competent, brilliant adults, not just superficial, vain teenagers. And that's not about just eat, because it's ironic that the solution to her problem, the nutritional, medical, malnourishment problem, is just getting in the calories. And to the vast majority of us, the idea of giving up your entire life because food is so appalling makes no sense. For us, food is joy, it's culture, it's nourishment, it's pleasure. But for these patients, it is truly anathema. And when it's this intense, you end up in Christy's situation. So there's some key concepts, and there's a couple of different pathways that one can go through when thinking about how to take care of these patients. Always, you start with keep working to motivate the patient. And I will talk in detail about harm reduction and where I bring that into the bedside when appropriate. Or you have the option, as I did with my first patient that I showed you is in recovery, and you can threaten to or take their autonomy and treat them against their will. I took care of another fairly dramatic situation with a patient where she's 35 years old and she had been a nationally ranked gymnast. I saw her YouTubes from when she was a gymnast at age 14. And when she was a gymnast, she was 4'9" and about 75 pounds. And she looked okay. She looked like a thin, muscular little gymnast. But from that time, about the time of her national championships, to the present, she had had critical anorexia nervosa, and she was deeply mentally ill, even though she too was brilliant and an amazing communicator. And so she came to acute and bottomed out. She was now 4'6" because she had such severe kyphoscoliosis from her osteoporosis. She's now 4'6", and her weight bottomed out at 37 pounds. And she, being from the Midwest and living with her family, said, there is absolutely, Dr. G, no way I'm going to die from this. I won't do it. But I also won't eat. And I said, well, there we have a problem. So I said, here's the deal. You haven't been in serious treatment and fully weight restored ever. So even though you're in your mid-30s, I'm going to use the option to place you on a court hold and force you to eat if you won't do it yourself. And she said, well, how dare you? This is ridiculous. How can you take my autonomy? I am an adult. And I said, but I will, because you haven't weight restored recently, and I don't know what your brain does when you weight restore. But we'll talk about harm reduction. And if you stop eating, I will place a feeding tube, and I will restrain you if I have to. And she said, Dr. G, The last thing that I want is a feeding tube. So here's the deal. You keep holding that over my head and I'll eat. And I said, okay. And I put her on a court mandate. And every day she would just check in with me and say, if I don't eat my 2,200 calories today, Dr. G, are you going to tube feed me? And I would say, I sure am, sweetie. And she would go, okay, bring it on. And when it came, she stayed at acute for a long time because she was so ill. When it came to having her court hearing, she and I sat together. I mean, we were practically holding hands. The magistrate was like, I've never seen a more agreeable patient. And she was like, oh yeah, this court mandate, this saves me. I wouldn't do this if it weren't for the threat of tube feeding. So this has saved me, and Dr. G has convinced me, and I'm doing this. And she left acute at about 55 pounds and managed to sustain that weight at home with a better quality of life, always with the invitation to return to complete the work. So that's an option. Or, and we'll talk about when this is appropriate, as in Christy's case, permit them to continue to refuse food and lean in and support them emotionally and physically until the day they die. So we start with motivation. You need clinicians with real eating disorder expertise, and you've got to give it all you've got. And that's one of the things that's challenging to those of us who take care of patients with eating disorders, because how do you authentically bring all of that passion and commitment without so pouring your soul out that you end up completely empty by the end of the week? And the answer, of course, is that we always have to focus on our boundaries, our self-care. Just like you can't go through the day and then take a breath, you can't go through a day or a week and not persistently engage in whatever self-care recharges you to do the work. I consider a time-limited trial of treatment with patients, and a lot of these precepts are really familiar to those of you who do palliative care work or who do internal medicine or really any care with patients, just like we do in the ICU. And the family says about their septic loved one, do everything, keep doing everything. And you know that the patient has no chance of survival, but you realize that this is a family situation, it's not one individual situation, and you say, for the next 3 days, we're going to continue to give it all we've got. And these will be the markers we're going to look for when we understand that it's simply not going in the right direction, or that your loved one might be suffering more, and those will be the markers we'll have to pull back. Very similarly in anorexia nervosa, and of course, as I'll discuss, I'm only doing this with my grown-up patients, you know, my 30-year-olds and above, is to say, what if? Because every day right now is a torment. Every day that I put a tray in front of you, you've got two little voices and they're tearing you apart. If you eat the meal, you're failing your anorexic, and she's furious at you. If you don't eat the meal, you're failing your healthy, wise mind, and she's furious at you. And every time you sit and approach the table, it's tearing you apart because you're failing a key component of who you are, and it is exhausting to do that. How can someone constantly fighting that fight have any energy to do therapeutic work? It's too exhausting. So I'll say, what if you suspend the eating disorder voice for a time-limited period, say the next 3 months, the next 6 months, and you say, I don't have to wholeheartedly embrace what's happening right now. I don't have to say, yeah, I want food and I want my body to get bigger. What if you decided, I won't resist for 3 to 6 months? And you engage in therapy, you tell the eating disorder voice, later, I'll come back to you later. I'm not signing you away altogether. And then you say, well, if it's still 2017, I guess I'm still trying recovery. And I'm not going to lie to you. My hope is that as you get nourished, as you actually engage productively in therapy, you will come to the realization that this is what you want and this is something you can sustain. But if you get to that point at the end of your time-limited trial of therapy and your body weight is restored and you've engaged in treatment and you can't do it, I will support you in hospice. If you have to relapse, if this isn't working for you, I will support you. And I've had a number of patients for whom this was sort of the thing. This was the thing that got them over the hump and allowed them to stop the exhausting multiple time a day resistance and kind of engage in the process, including some of my patients who were in their 50s. That really kind of appealed to them. All right, I'll try. Now, harm reduction is really important, and it's always reasonable to allow every patient, to invite them to say what they want, to take a non-assumptive perspective as an internist, as their physician, and say, it's not, here I am, I'm a healthy doctor. I'll stand here in my privilege with all the things that I have going for me, and you're just the patient, so you have to do what I say. Instead, we say, how can I serve you? What would make this worthwhile to you? And we ask that of our adolescents as well, but for adolescents and those early on in their disease, it is always and only appropriate to insist upon a full course of care. Harm reduction is not for the very young and for the new to the disorder, because you just don't know what their brains are going to do. Even my patient who bottomed out at 37 pounds, 2 or 3 weeks into her stay, I went into her room and she goes, Dr. G, I actually feel better today. I said, oh my gosh, I'm so glad to hear that. What do you think's behind that? She goes, oh, it's the nutrition. So we don't know what these little brains do as they start. In fact, I'm struck by the fact that my patients at the end of a 20, 30, 40, 50-pound weight restoration one day look in the mirror with a brain that's nourished and go, oh, I'm slim, when they were weeping about their fat thighs 40 pounds later. And we know from the Minnesota experiment that people's brains get funny on starvation. The Minnesota experiment was led by Keyes, who took a bunch of conscientious objectors during World War II and said, all right, you don't have to go fight, but we'll starve you to understand what's going on with our soldiers overseas, because no one had ever really studied what happens physiologically when you starve. And so all of these robust young men, without those temperaments on the end of the bell curve, and without being in a society that was fat-phobic and thin-worshipping, ran long hours, did heavy manual labor, and had a highly restricted caloric diet until the point at which they were about 75% of expected body weight. I mean, 75% of expected body weight for my former patients is like astoundingly good. But these guys got down to 75%. And Keyes made all of the observations, the early observations about what happens to someone when they starve. But most surprisingly, the psychological effect was devastating on these guys. They would go into cafes and not be able to eat and watch and write in their journals about how gluttonous the people were as they ate their food. They started, when they were fed, cutting up food into little tiny pieces, putting it in their pockets for later, getting weird about food and feeling distorted in their bodies. And they describe the torment of years later continuing to feel, even once they were back in normal-sized bodies, wrong. So there is something about our brain on starvation that gets weird. And that's why I'll often tell my patients, the feelings you have, the emotional distress you have right now may not be Christy. It may not be Christy's anorexia. It may be Christy's starved brain. So hang in there and keep pushing through. Let's see how your brain does. With harm reduction strategies, when it comes to adults who have been through big treatment before, they have tried restoring weight, it didn't work, we say, okay, what if we establish a weight goal that's well below typical, because apparently a fully restored brain doesn't work for you, and we allow you to envision a meal plan where you still feel that you're restricting something and controlling that, if that control-nitis is the only way you can get through life. And we say, never below this point. Would you be able to do that? And interestingly, some of them say yes. If I could never be above 85 pounds, if I could be never above 90 pounds, but I could go to my job, I could take care of my dog, I could see my family at Christmas time, I think I could live with that. And the permission not to have to get to a point that has previously been truly intolerable can sometimes be that middle ground where you say, okay. And listen, as a type A, anxious, perfectionistic physician, I can assure you that that kind of half-assed approach is not always comfortable for me. I too want to be the one who always saves the patient and makes them happy and gets them fully better. And there's plenty of societal disapprobation of sort of, what? You permitted her to stay sick? You permitted her to die? But I've been in the trenches with these patients, and I know that there's not one size fits all. And so I have to sit with understanding that it's not about me, it's about them. Guardianship and civil commitments. So there's two pathways down which we can go when it comes to taking a patient's rights. And we have to be pretty thoughtful about that, because taking someone's autonomy is a big deal. If we go down the medical arm, we say, we're taking the anorexia nervosa out of it, but by virtue of this individual's profoundly starved brain, hypoglycemia, and organ failure, we feel she is cognitively impaired due to a medical problem that she can't verbalize and repeat back the ramifications of what's at stake. Therefore, we say she lacks capacity. We have a power of attorney, hopefully a family member, make decisions for her. And we appeal to the courts to say, hey, look, she's going to need tube feeds. She's going to need treatment against her will on the medical side. In the state of Colorado, though, medical side, including proceeding to full permanent guardianship, will not permit admission to a psychiatric facility against a patient's will. So in terms of the hospital situation, and I'm sure Oregon law is different, we can keep them in the hospital and not have them leave AMA, and we can treat them under guardianship and civil guardianship. But when we think about having them proceed on to an eating disorder treatment program, we have to go down the other arm, which is down the mental illness arm. And down that arm, we say, well, look, the malnutrition part, we've got the edge taken off of that. But this anorexia nervosa is so severe. This patient is wearing her anorexia goggles, which are giving her such distorted views of herself, her body, and her food, that she cannot feed herself, clothe herself adequately. She is gravely disabled, and we're going to have the courts place her on a short-term certification, which can allow in Colorado up to 90 days of treatment in a psychiatric institution against the patient's will. And those are the two arms that we have at our disposal in Colorado. But when is commitment not right? Because this really comes into the sort of blurry, ethical, challenged, infused concepts. Even if one of these patients sort of meets a lot of these mental health criteria, they still may not be appropriate for civil commitment to a mental health institution. For instance, someone with repeated elopements. You know, we've got plenty of patients, I've taken care of a lot of them, who just keep running away. Even if they're in a locked ward, they find the opportunity and they get out. Patients with a prolonged need for involuntary tube feeds. There comes a point at which all of the staff becomes so traumatized by a brilliant and articulate person saying, you are tormenting me, you are killing me, how can you do this? That we have to eventually say, no, we're not going to keep putting people through this, the patient nor the staff. Multiple previous treatment programs without success. Older age, typically 30s and above. And then patients who meet criteria for harm reduction, palliative care, or hospice. None of those are the ones we civilly commit. And, you know, I get calls, and I did more when I was at Acute, from, you know, a lawyer in Texas whose sister is 50 and is an alcoholic and has a raging case of anorexia nervosa and Would I try to sneak her across the state border into Colorado, civilly commit her and force her to treatment? Nope. No, I sure won't. And so on that call, I have to bring up these concepts and empower her with the knowledge as I hear the story of this individual's and her family's suffering, that it sounds like they have done everything and more that is possible. And to empower her to know that it's not that she's allowing her sister to die. The disease has selected. The disease will cause her sister to die. It's her place to decide what the family dynamics are going to be as this tragic situation finishes out its hand of cards. The framework for palliative care in anorexia involves the following questions. Is the patient 30 or above? Or, much more rarely, and this really gets on the borderline, if they've been sick without meaningful remittance of disease since childhood, and they're in their mid to late 20s, when kind of the brain is finished myelinating and you think that they were going to get that last maturity bump in their mid-20s, they've got it. Maybe those patients as well. Have they completed the gold standard of care, full weight restoration in a good, high-quality program? And do they have the capacity to make medical decisions? And there are people who will make you think, surely the suffering is enough. One of my very favorite patients, whom I've been the doctor for the last 10 years for, in and out of acute, she'd go to programs, she'd leave programs, she'd relapse again, try it again, came into treatment about 2.5 years ago at acute, critically ill once again. And she's in her late 20s now, and she said, Dr. G, I just don't know if I've got it anymore. And I knew she had been sick since the age of 10 years old. And she has suffered so much. And this was a patient who was so mentally ill that she actually gave us a list of the ways she has scammed treatment programs before, including my own. She was like, I love you, Dr. G, here's the cheat sheet. And I mean, this kid was so sick that she would steal needles from the sharps box and phlebotomize herself in the shower because to make blood takes calories. So I talked with her and I said, okay, I'll do this with you. I'll support you in palliative care if that's what you have to do. And we sat together, and I mean, one of the great joys of being on the hospital side, and now I'm an outpatient, is to have that luxury of time, which so few of us as physicians have anymore. But you know, I have no patients in my waiting room if I'm a hospitalist. So if I want to take an hour with a patient, it's just my time. And I really love that. And we sat for a long time, and we listened to For Good, the song from Wicked. And I left that afternoon with her crying and saying, I can't do it. Tomorrow we'll talk to my family. And I said, okay. And I came in the next morning, and she said, nope, Dr. G, I made a mistake. I can't die. I have a niece who's going to be born soon. I have Star Wars movies that are coming out that I'm going to need to watch. I have a lot of books that involve dragons that I'm going to need to read. And I can't die. I'm not going to do it. I'm going to live. I'm choosing life. And she completed her treatment. She went on and completed treatment in a really good eating disorder program, and this time it stuck. And she's been in recovery for about 2 years now, and I just went to her wedding as her internist. And she had a fairly conservative family who was all there, and she had the DJ call me to the dance floor, and she played For Good, and we danced. So these are hard situations. You have to just keep sitting in the gray and keep listening and staying flexible. Capacity in anorexia is exactly the same as capacity in any other setting, and you guys know these criteria, how we decide to know that a patient has the ability to make good decisions. And it was asked after my lecture yesterday, you know, what if the patient is super, super starved? How do you know if they can make these decisions about what they want for their care? And I said, you know, there's no There's no test. It's still asking. It comes back to asking the questions. Asking in anorexia specifically, what are the benefits and burdens of going through residential treatment again for you? Let me not be assumptive. Tell me about your perspective. What are your goals for your quality of life, and why now have you felt like you've hit a wall? We stay non-assumptive. We try not to tell them, just eat, just try one more time, just go to treatment again. Anytime we use the word just, we are understanding intuitively that there's far more to it than we're letting on, and we're minimizing the other person's experience. And we have to recognize that perhaps the suffering of the mind might be as legitimate and real as the suffering of the body. So there's a writer, a scientist who herself recovered from a critical eating disorder, who now writes in the literature and suggests that patients may decline care when they're competent. But remember, a competent patient may still have the distortions of the eating disorder. They may be medically competent and say, I'm fat and food will make me fatter, and that is intolerable, while they have a BMI of 14. They have a realistic expectation regarding the outcome, knowing and verbalizing that refusing nutrition will lead to death. They must be able to express that their decision is based on a realistic assessment of their quality of life and the low probability that ongoing treatment will make a difference, and that they're consistent. I won't read this long quotation, but severe persistent mental illness, or SPMI, has been acknowledged by the Swiss Academy of Medical Sciences guidelines on palliative care as certain mental illnesses that may well be appropriate for palliative care, including refractory anorexia, severe schizophrenia, and patients with multiple suicide attempts. And so palliative psychiatry specifically focuses on providing the patient and their family support in dealing with and accepting really critical mental symptoms, affirming life but acknowledging that SPMI may not be survivable. That, of course, always we never intend to either postpone or hasten death, but that we integrate all of the aspects of the patient, seen as a whole individual, into the discussion, offering a support system, using a team, and trying to help with quality of life. We've talked about who are the candidates for palliative care, and it's very important to remember because doctors are measurers, perhaps no more so than now, when our reimbursement and our hospital satisfaction and our patient satisfaction emerges from the numbers that we contribute to. That there is not a magical weight or number of hospitalizations or any other measurable feature that clearly says this patient may go to treatment. So we have to keep talking with the patient. And I've been very struck in my work with anorexia nervosa, particularly when patients have concurrent conversion disorder, somatic symptom disorder, that I have to revert back to some of the really ancient roles of a physician, where I acknowledge humbly that I can't fix them. I may not be able even to ameliorate their symptoms, but I can bear witness. And this is one of the things that brought many of us into this field as clinicians, is to sit there and say, in your distress, where I apparently cannot do anything to help that, I will be with you. Ultimately, it's the whole story of the patient that guides us towards these critical decisions. What the situation isn't is, so you want to die? I can't tell you how many of my patients have been asked that in hospitals, in mental institutions, when they won't eat. Or even when they say, I can't do this anymore. People stand over them and say, so you want to die? Take a similar patient of similar age, a 35-year-old with terminal breast cancer, who's been through every treatment she possibly could have at great personal cost, and the cancer keeps coming back. Would anyone in this day and age say to that woman, "So you want to die?" when she says she doesn't have it in her to go through another experimental course? It would be appalling. And yet my patients hear that all the time. Therefore, just eat is akin to just get those cancer cells to stop replicating. It is not possible, and we mustn't engage in that kind of discussion. So what makes anorexia terminal? It's not that there's no cure. We know that the food will fix the malnutrition, and that therapy could, and medicines could fix the mental illness. But it's their inability to accept that the critically low weight is truly life-threatening, because all of my patients walk through the day thinking they're fine. That's what the eating disorder tells them every day. You're not sick enough. Look, you can still get a 4.0. Look, you can still work a job and be the star employee. In fact, this concept of "I'm fine" is something that I like to counter with a particular metaphor. I was an English major, and so I love speaking in metaphor in order to try to get around the anorexia goggles, to take them off for a moment. And when patients tell me, "But Dr. G, my potassium's okay. But Dr. G, I'm able to go to work every day," I say, I'm going to tell you the house on fire metaphor. And the house on fire metaphor goes like this. There's a young woman standing outside her burning house. The fire department comes screaming up and they say, "We're here to put out your fire." And she says, "What fire?" And they say, "Well, your fire. I see the flames. I feel the heat." And she goes, "No, if I had a house fire, it would be so hot that the sidewalk would be bubbling. And since my sidewalk isn't bubbling, I clearly couldn't possibly have a house fire." And they understand she's mentally ill, and they put out her damn fire. And so every time my patients say, "But I can go to work, but my potassium's normal," I'll say, "Sidewalk." And they'll go, "Okay."
Whose brain ain't yours by silver elevators? Whose brain ain't yours by silver elevators?
The patients want to live, but they can't do what's needed to stay alive. And it's this tension when you see someone who's so brilliant and articulate, witty, compelling, but who then looks at herself and is dismayed and disgusted, that makes us all question, can we really trust this person's decision? Can we really allow her, when her reasoning is so funny, to keep not eating? Options and offerings for palliative care and hospice. You may have to do a lot of convincing and educating. I couldn't do it with the hospice situation in Virginia, no matter how much I tried. I spend a lot of time on the phone. Supportive therapy is appropriate. Medications for anxiety and depression. A commitment that I will not force you to go into treatment even when you get critically ill. An offering that if you change your mind, you are always welcome to seek full treatment again. And yet, not offer that so distinctly each time that you reopen the wound that the patient, who feels terrible and guilty and sad, has already tried to heal in making the decision, "No, I am not re-engaging treatment." And intensive support of the family. And when I tell my patients, even in my outpatient practice now, because I just had one of my dear patients leave acute against medical advice, and she's 50 and is the mom of 12-year-old twins and the wife of a guy she saw through a heart transplant, is, okay, if you leave, you will eventually die, and I'm here. Let's talk more. I'm here to help you in whatever way I possibly can. You're not alone. Always supportive enumeration of what to expect is appropriate. And as we saw in Christy's tragic case, it can take a long time to die of starvation. I don't know why, I don't know how she managed to live down into the 30s pounds at 5'2". I mean, it just beats all medical reckoning, but these patients are tough. And we're all here because the human species has evolved extraordinary ways of surviving famine. So we have amazing, robust ways to stay alive in the face of food deprivation. Medical equipment in the home is appropriate, and all of the ongoing family support. Ultimately, I know that you all believe in this because you're here, but every person with a potentially fatal illness deserves to have a compassionate, educated talk about the potential for death. I'm amazed at how many of my patients for acute, despite being the sickest in the country, had never had a doctor sit with them and say, okay, what about death? Let's talk about it. Instead of just being finger waved, you could die. If you keep doing this, you're going to die. Ew. My patients really appreciate this being brought up because they've thought about it, oftentimes a lot. My final slide is my favorite one to end talks with. The title of this slide is Know When Your Ass is Overwhelmed. And it's so important for us to take care of ourselves, and while it's rare in the field of medicine, to really take care of each other so that we can do the work we have to do and live in a non-judgmental way and understand every individual has different needs, different struggles, to stand in our privilege and to always be willing to acknowledge that we're human and we have to do what we need to do in order to keep offering to others. These are my references, and I would be delighted to answer any questions.
So just a reminder, it is 9, so for those of you that need to leave, you can stand. But for those of you who can stay and would like to participate in some question and answer, we do have the next 30 minutes, so dig in if you'd like.
Let me give about 30 seconds for those who need to clear out to be able to do so, and then we'll take some questions, and I'll get you first, Dr. Kumar. Okay, Dr. Kumar, your question is.
What is your success rate for eating disorders?
What is my success rate for eating disorders? Great question. I've only had my clinic open for 6 months, and I'm half empaneled. I'll probably be able to see 60 patients in my panel because they're pretty intensive. And so of my 30 patients, to my great chagrin, I've had at least 7 have to step back up into residential care. Ouch. But of the others, I know that I'm keeping more in their communities because I'm able to support their psychologist and their dietitian and give the same consistent messages and not reinforce the message of fine that so many of my patients hear from their physician. When it comes to our success rate at acute, up until the time I left it last summer, had never had a death on the ward, which is pretty remarkable for patients who were that critically ill. The long-term success, we don't have data on. And it's a little bit like asking a trauma surgeon who takes care of a young man in a gang who's shot, did that gang member end up returning to society afterwards and escape the gang and get a job and have a happy quality of life? It's a little hard to look down the road, but it's a relevant question. Yes, please.
You talked about adults. How many of those adults started as adolescents or younger? And what are your approach, or what do you think about the medical profession's treatment of adolescents and young people who grow into your problem?
The question is, how many of the adults I take care of started in their adolescence, and how was their care? Virtually all patients with eating disorders start with something in their teen years, sometimes earlier. It's getting earlier and earlier. My colleagues in the residential treatment field say that they're seeing children as young as 7 who have true full anorexia nervosa. I would say that pediatricians and family practitioners do a radically better job of treating children and adolescents with eating disorders than their adult counterparts. This is why I'm only one of 2 peer internists in the country who's a certified eating disorder specialist. So adult doctors do a really bad job of this, in part because of the system, the system in med school, I got 0 hours of training in eating disorders throughout my medical training. And doctors don't like what they don't know about. In part, the medical system in the Q8-minute visit really massively impacts how these patients are treated. In fact, I have colleagues who see these patients and have had to break out of their even pediatric practice because all of their colleagues say, stop. These patients are taking you an hour and a half. You could see 7 patients during that time. I don't want you to see eating disorder patients anymore. And so they have to break out of the practice and set up their own shop to see them. So I would say that in the adolescent population, they get better care, but the data are still catching up. You know, the business of eating disorders probably got ahead of the science of eating disorder treatment in many ways, because once residential programs learned that they could charge $1,800 a day for 6-month stays, you know, anyone with a yoga mat and a pony could hang up a shingle and say, we're an eating disorder treatment program. So that's a problem. But as the data continue to come in about good treatment, we learn, for instance, that while we used to think that refeeding syndrome was the biggest thing to watch out for and you had to start them really low, we now know that the underfeeding syndrome is far more dangerous. And at acute, they start patients at 1,600 calories a day. And Dr. Cohn out of Sydney in Australia is starting his adolescents at 2,500 calories a day from the get-go. Go, feed their brains. So I think without a lot of physician support in the field and with limited data, early treatment efforts have been wobbly, and we're trying hard to catch up. Yes?
You use the word recovery a lot, which of course evokes addiction. What are the similarities between anorexia and addiction?
That's a great question. The debate rages on. And I'm not familiar enough with the functional MRI literature, and I'm not a psychiatrist to be able to have a strong grounding in addiction medicine. But what I'll say is that some of my patients feel like this is an addiction. They feel that the habituation, the safety of engaging in behaviors permits them to get through life. Many of my patients have comorbid addiction. It's typically my patients with purging anorexia or bulimia nervosa who have comorbid alcohol and drug addiction. And of course, that group gets really, really failed by the system, because if they're in drug and alcohol treatment, they're engaging in their disorder of the eating disorder. And when they're in eating disorder treatment, they're engaging in their addiction. So they never get fully sober from either of them. But there are differences as well, because there's not a withdrawal from not eating in a way that there's a withdrawal from not using alcohol, for instance. But I think that there's a lot of overlap. And you know, it's not that the therapeutic modalities are radically different. CBT and DBT and ACT, I think all of these probably have Venn diagrams that overlap in the appropriate care of these folks. And when I'm trying to describe, oftentimes to fix-it daddies, how hard it is to recover from an eating disorder, I'll use a more familiar model of drug and alcohol addiction, and I'll say, imagine you have a friend who's lost everything to alcoholism, and he's finally ready to get sober. And you say to him, great, happy for you to get sober. By the way, for the next 5 years, every time you sit for a meal, I will have prepared for you 3 shots of Jack Daniels with the bottle on the table and the cork out. So that if you've had a fight with your partner or a tough day at work or you've had an anxious experience, every time you sit down for a meal, all you'd have to do would be to reach out and use. And people are like, oh, that would be impossible. And that's what I say, you know, that's what your kid is going to go through every time they approach the table. Because every time they approach the table, they have the opportunity to use a little of that behavior, to restrict a little, to leave the table a little hungry. Wow, this is hard. So it's a great question. Yes, back there.
Too, you talk about not great treatment programs. What are the components of a good treatment program?
What are the components of good treatment programs? There's a couple of things. First of all, inpatient, residential, partial hospitalization, IOP. And I know that this system has a terrific program over at St. Vincent's, IOP and PHP, I believe. Really good programs need to have excellent doctors, excellent psychologists, excellent master's level therapists. They need to have robust and well-described therapeutic modalities. They can't just be sort of taking a smattering. They need to be able to individualize care and track patients. You know, if there's an older population, if there's a comorbid substance use disorder population, they need to be able to either accommodate or give a reason why they can't accommodate a full gender spectrum and be able to acknowledge competency in people across a spectrum. They need to be able to use best medical practices and have robust ways of taking care of patients. So there were 1 or 2 programs when I was at Acute that Acute would reach out to and say, hey, when patients call in who are clearly too sick for you, send them to us first, we'll fix them, we'll send them back. And they would say, oh no, we do all that. And you just knew they couldn't possibly. So you want people to know who their patient population is and isn't, and have the integrity in a money-interested world of being able to hold that line. Yes?
How do you speak to co-occurring substance abuse disorder in a patient who has been treatment refractory, that you're considering a palliative approach, but how can those conversations go when there's kind of a constant state of being drug affected? And also thinking about the ethics of that.
So if we're talking about comorbid ED and substance use disorder in somebody who may well qualify for a palliative approach, how does substance use disorder and chronically being on the substance in question affect the ethics and the practicalities of that? And I think the answer is, you're right, that makes it a whole step harder. And you ask the same questions and you talk to the same family members and you try to get a sense, was this person ever sober? And when they were sober, were they a totally different human? And if that's the case, is it worth finding a place that does the concurrent care, and I can tell you a place or two afterwards if you want, and give it one more really strong try and see? Because if they've never been sober or weight restored or both at the same time, maybe it's worth another try. And if not, it makes it more complicated. And bless you for working on it. Yes?
So I was curious, actually, kind of in follow-up to the kind of frameworks of things to look at for like a good inpatient treatment. It sounded like that was especially, like, would you say that that's true, or do you have any specific guidelines or recommendations for places to go for guidelines as far as like hospital inpatient versus residential inpatient or whatnot?
Yeah, and come up to me afterwards. I'm more than happy to give you like a short list of really top programs, none of which I have a financial interest in. I think St. Vincent's has a good relationship between the hospitalists and the eating disorder program, so locally that feels like it has potential. I think if you have a really sick patient, the only place I would send them to is Acute, my former program. And let's talk afterwards about some really good IP res programs. Yes?
I'm a dietitian outpatient that primarily works with people with eating disorders, and one of the biggest challenges for me is finding doctors that can assess medical stability, because that's part of my decision about whether I can actually treat somebody on an outpatient level. I'm wondering, as a physician, do you have recommendations about how to try to cultivate more interest and education in a collaborative way in a community?
Yeah, so the question is, as an outpatient RD treating patients with eating disorders and with very little physician support, you're basically asked to de facto assess stability yourself because nobody has the expertise to do so. And even if someone tried, you're not sure if you'd believe them because they don't have this expertise. It's the most common question that I get. I'll let you guys know I'm fully licensed in Oregon because I do telemedicine. I'm licensed in 10 states. I don't take insurance yet, which hurts my liberal heart, but for patients who have the means, they come to Denver the first time, and then I can follow them in telemedicine. And I work with multidisciplinary teams around the country. In the meantime, the Academy of Eating Disorders has a really good, brand new PDF that you can find on aedweb.org, which is a physician handout to say, here are the fundamentals that you need to know as a physician who encounters someone with an eating disorder. Here are the tests to run, the vitals to look at, and go. So at least that's something that you can offer a physician who remains curious and open as a way of improving their knowledge base. But, you know, I'm grateful for the work you do, and it's really appalling that people have so little doctor backup. Yes, sir.
How are you able to do everything that you do?
What a lovely question. Sometimes I'm not, is the answer. I think this election has shown me more than ever that if I stand in my privilege, and that includes having been in love with my husband for 21 years and having 2 little daughters that I adore and are healthy, and all of the other benefits that I've been accrued, that I'm able to acknowledge my humanity and that I need to take my weekends off and my evenings off with my family and do the things that keep me strong to do this. And it's hard to admit that because all of us here have a lot to offer. We have big engines, we've got a lot of energy, and we are called. And everyone has their own individual challenges, but I feel, sitting in gratitude, I feel so grateful every day that I get to do this work and then go home and be a wife and mom, which are equally important to me. Yes?
Yeah. You began by saying that this work was an integration of the body and soul. And toward the end, you talked about how once someone was on hospice, if you could get them to that point, that they'd have an integrated team. How do you use chaplains or spiritual care in the middle?
Wonderful. Spiritual care deserves to be infused throughout the entire spectrum, as long as that's of interest to the patient. In acute, of course, in my prior hospital, we had wonderful chaplains on staff who were part of the weekly care team meeting. Every patient was invited to receive spiritual support throughout their stay, and many took them up on that. And always, when caring for patients, making sure that their spiritual needs are kindly, specifically attended to is vital. When patients' specific faiths weren't represented adequately in the chaplain services we had, we would often call into the community and see if a rabbi could come in, see if somebody else could come in who could really speak to them personally. And in my current outpatient system, because patients are living at home and living their lives, they are engaging in their spiritual lives to a level that feels appropriate to them. Yes?
I was wondering about treatment for patients where they understand their anorexia as religious fasting.
Patients who understand their anorexia as religious fasting. Certainly the earliest cases of anorexia nervosa were recorded by physicians who attended upon saints who were so holy and abstemious that they simply didn't need food. And there's an interesting theory that one of the ways that religious women gained power back in the 1500s, 1600s, 1700s was to need nothing. And they actually gained power through their ability to resist earthly things. And of course, the story of eating disorders has to be the story of the patriarchy and of feminist theory, even as men are involved as well, because the thin ideal is one that women have absorbed from a male culture that insists upon it and glorifies it. I think in the modern day, it is vital to let patients know that it's unacceptable to express their religiosity through this kind of personal treatment. That their faith is something that you respect and you honor, but that it would appear that a mental illness has taken over that airplane and is running it for its own purposes. And I'll often say to my patients, you know, if God had only given you a Tonka truck instead of a big badass warplane to fly around, you wouldn't have gotten so far. But your pilot has been taken over by anorexia nervosa. And if you were in a little Tonka plane, deet, 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 no problem. But you know, you have so much equipment here that when your pilot gets taken over by anorexia, there's nowhere you can't go and no one you can't convince. And so to say, how can we honor your spirituality while also understanding that there must not be a God who would insist upon you having organ failure, weakness, and frailty in his name? Surely that can't be a part of this spiritual world we live in. Yes?
So what percentage of your patients are Jewish?
What percentage of my patients are Jewish? A large number. Tell me, you clearly know, so tell me more.
So what do you see, is there something about Judaism or something about their way of life that brings it on?
Is there something about it? That triggers, is there something about Judaism that triggers eating disorders? I think not. What I will tell you, though, is that I've had many patients who are the grandchildren of Holocaust survivors. And one of my patients actually wrote her master's thesis on alexithymia in grandchildren of Holocaust survivors. And alexithymia means the inability to name your emotional state. In her experience, and she came from a delightful family, a delightful Orthodox family, who dad is a doctor, mom was at home. She was a hypersensitive, emotionally, highly intuitive, brilliant girl who grew up into that same as a woman. And so she felt things a lot. And that's really common in my patients. They feel, they have, I like to say, because I'm a little bit of a Greek mythology nerd, that they have emotional radar like Argos all over their body. And so as a little kid, when she would start to come to her parents and say, I'm sad, I'm mad, my feelings are hurt, I don't know what to do, her parents, who were really well-meaning, and I'm not a parent blamer, parents are part of the solution, would say, oh, really, you're sad? Think about what your grandmother went through. And they weren't meaning to be mean. They were meaning to toughen up their little tender petunia, to sort of be like, come on, kid, get it together. You don't have it so bad. But what she heard in her sensitive soul that turned into borderline personality disorder was, be fine. And so when she heard be fine, she was intuitive enough as a little kid to understand, this is the message my parents are giving me. But she kept absorbing all of that same emotional stuff. And it became a maelstrom in her. And sometimes I wonder whether my patients feel so big because they have such big emotions sloshing around inside of them with nowhere to put them. Because the vast majority of my patients haven't learned the fundamental traits of, or tasks of, I know how I feel, I'm kind to that feeling, I know how to soothe myself. And so what I see in a number of my Jewish patients is this same kind of relativistic, how can you possibly say you're feeling crummy when our family has been through this thing? And unfortunately, they don't say, wow, you're right. Mom, I'm actually still sad because I'm really an emotional kid and I'd like you to teach me some skills for what I do with that and also show me compassion because I'm probably going to be emotional the rest of my life. You can't say that at 5. You can barely say that at 40. So I would say that I do see that. Yes?
So as a hospice nurse, I've seen very few patients with this diagnosis, but I have seen it. And what I've noticed, which was kind of disturbing, was while hospice is comfort care by definition and largely symptom management, there still seemed to be some resistance to the diagnosis by the team. and a wish to try to help this person see that they should seek treatment. There was this undercurrent. It wasn't always said that way, but it made me think, so what would be a good plan of care for a person like this, if this was their decision and their choice, as if it was any other illness? I guess my question is, what would be a recommended plan of care, knowing that it would be individualized?
What's a plan of care for a hospice nurse for a patient on hospice who may or may not think she's even going to die of her eating disorder, and whose team secretly kind of keeps wanting to push her back into treatment, even though the handshake has been established that no, you don't have to do that anymore, which of course we talked about is quite unfair to someone in this situation. The vast majority of my patients don't believe that they are worthy of rest and worthy of comfort. In fact, if given an option to sit in a hard chair or a soft chair, they will always pick the hard chair because they are less worthy to sit in the comfortable one. And interestingly, again, as all of us achievers in this room raise children and exist in our society, keep in mind your own projection of, no, I'm fine, how can I help you? Because your children are listening. And many of my patients say, my mom was a saint. She took care of everybody. She was so generous and she never took time for herself. I'm much worse than my mom is, so how could I possibly be worthy of rest and goodness either? Remember the effect that our giving natures have on others. I think that a hospice plan probably involves coming in, establishing a warm rapport, exchanging stories, hearing what the person wants to do. Well, I really want to walk my dog. All right, great. As you get weaker, how are we going to do that? Can I plunk you in your wheelchair and we'll tie the dog to the wheelchair and we'll go for a walk? How can we allow you to live the things you want to live and enjoy as best you possibly can while you can? And, sometimes expressions of worry or fear are hard for my patients to hear because they're like, no, I'm not that sick. Come on, stop it. But a lot of the time, it's touch. Nobody wants to touch my patients because they're so thin that it feels we've got a little bit of an animal, like, no, something's wrong here. And so an internist who never trained as a mental health professional, I offer my patients hugs, but making like everybody needs touch. And just saying like, how can I help? What can I do? Are you getting up from the toilet okay? You need a rail? What can we do? And that's ultimately just continuing to listen and ask, how can I serve you? What can get you a better quality of life is going to be individualized to each patient. Thanks for what you do. Yes, sir.
I work in long-term care of the elderly, and we've had a couple of these cases over the years. And the treatment team has went through ethical consults and clinical consults and all kinds of support to finally come to this decision and allow the patient into what can we do to support the caregivers in an adult care home or a residential care facility who haven't been through that whole decision-making process, and they have to watch somebody take 2 or 3 months to die this very slow kind of death?
Yeah, that's a great question. This is hard on staff. Any of you here who work with patients with eating disorders know this is incredibly hard because we still don't know enough about this. And so we can't come to it with the natural compassion of those who wear the pink ribbon. There's no yay ribbon for anorexia nervosa. And they talk about that. They say, if only I had cancer, people would give me compassion and not question me all the time. But they just think that I'm being selfish, and that's like the opposite of what I'm doing. I feel like I shouldn't exist. I wish I didn't. To have, therefore, staff group support sessions, which probably is useful because I think, therapy for all, anyway, whether you have an eating disorder patient in your midst or not, people will be of varying levels of education who work in a long-term care facility. And they won't have some of the more sophisticated concepts of transference and countertransference that even I just barely understand. in order to understand why, when I walk into this room, do I have this wave of anxiety come over me that I then carry with me for the next hour, and it makes me not want to go in that room again. You know, to sort of have a process group that allows people to grieve, to understand that they may have their own feelings about, well, I love to eat. I don't want to die. My daughter might be, you know, whatever might be happening to allow them to process that.
So probably last question.
Yes.
Would you have any difference in how you would talk to somebody who was starting out at a normal weight, becoming anorexic, completely underweight, versus a very obese patient losing significant amounts of weight because they're hypocalorically restricting themselves? Or is the conversation kind of the same way in that regards with those two types of situations?
That's a really great question. Is it just the very thin that deserve our attention in this topic? The answer is absolutely not. Patients may be, and my next lecture covers this more in the medical complications, at a higher or normal body weight and be critically malnourished with just as many medical complications of weight loss and starvation as my patients with a BMI of 12. And again, as part of the stigma of size and shape in this country, it's really important for us to acknowledge that. And I've had patients who have had critically crappy care from their local doctor. One of my patients had had such bad dysphagia for a month as a result of her Ehlers-Danlos syndrome that she lost weight from 150 to 120 pounds in about 2 months, and she hadn't eaten in 4 weeks. And her therapist begged her into a local GI. She lives in Kansas. And the GI goes, and she's like, oh my gosh, this GI is going to immediately put a feeding tube in me. This is going to be a big appointment. And the GI goes, yeah, well, your weight's normal, so maybe we'll get you for an EGD, and would 2 weeks be okay? Toodles. And so that's when she ended up becoming my patient, and we ended up getting her a feeding tube and all of this stuff, because she was like, no one's paying attention to me because I'm not underweight. I already feel embarrassed about my weight. What's going on here? So I'm happy to stand around for a few more questions, and I thank you so much.
Let us thank Dr. Gaudiani.
Jennifer, have you read about psychoanalytic approach?